A vaccine built for one Ebola is fighting another. More than 16,000 doses just landed in Congo for a Bundibugyo outbreak, killing about half it in facts, with no license protection for this strain and a death rate that doubled in 20 days. Will a stopgap built for a different virus offer any real cover before a tailored shot can arrive?
The most consequential change arrived August 22 in Kinshasa. A first batch of 16,250 to 16,520 doses touched down, part of a 70,000 dose allocation from the global stockpile managed by the International Coordinating Group, with about 50,120 expected by August 24th. The product is Ervebo, licensed only for the Zaire strain, now flown in as a surrogate for Bundibugyo, which has no licensed vaccine and no licensed treatment.
Care is supportive only. Among confirmed cases, the fatality runs about 47 to 50%. Latest consolidated counts as of August 19 to 21 put confirmed cases at about 5,290, with about 2,516 deaths and about 1,152 recoveries, with hundreds still hospitalized. The mismatch defines the response. The doses flown in have only laboratory and animal validation, with poor evidence of protection against Bundibugyo in people, about 40% genetic similarity to Zaire, and some animal data suggesting only possible partial protection. 50,000 doses are designated for frontline and health workers, 20,000 for a phase 3 trial testing whether any cross-protection exists in humans. No broader ring vaccination with this surrogate is confirmed. It is a bridge while strain-matched vaccines are still in human trials. Speed is the pressure. First detected in mid-May, the outbreak has become the country's largest in this period and its 17th Ebola outbreak overall. 2,500 deaths accumulated in 3 months. But half, about 1,250, came in the last 20 days alone. That doubles the pace to 62 to 63 deaths per day, up from 27 to 28 per day, averaged over 3 months. The burden is heaviest at the epicenter and spreading outward. Ituri carries about 4,447 cases and 1,984 deaths. North Kivu about 663 and 452. Haut-Uele about 160 and 71. Shopo 15 and 7. South Kivu 3 and 1. Bas-Uele 2 and 1. Uganda, linked to the same outbreak, recorded 20 cases and 2 deaths, now closed, with isolated detections noted elsewhere. Geography outruns containment. 54 to 56 health zones across 6 provinces are affected, an area described as larger than France, spreading from the Ituri epicenter through the Kivus and north and west to Haut-Uele, Shopo, and Bas-Uele. The replacement is not ready. The United Kingdom's Oxford candidate was developed in about 8 weeks, entered phase 1 in mid-July with first dosing around July 24th in 50 healthy adults 18 to 55, with about 620,000 doses manufactured and stockpiled by the Serum Institute of India and further studies planned, including in Uganda. In the United States, Moderna mRNA 1469 and other CIPI-funded candidates entered phase 1 in August. As of late August, no Bundibugyo-specific vaccine has emergency authorization for large-scale outbreak use, with efficacy trials in Congo projected no earlier than autumn. The official death toll carries its own contradiction. The health minister confirms more than 2,300 deaths and more than 5,000 people affected, while narration cited more than 2,500 deaths. Both reflect the same rapid rise, about 2,325 deaths around August 16 to 17, climbing to about 2,516 by August 19 to 21, and the World Health Organization warns the trajectory could now surpass the more than 11,000 deaths of the 2014 to 2016 West Africa outbreak. That threshold is not yet reached, but exponential growth has put it on the table. What is not counted may be larger than what is. African CDC estimates only 30 to 40% of cases are being detected, implying a true burden of 10,000 to 15,000, with less than 10% of cases found among known contacts and fewer than 40% with epidemiologic links. Turnaround from sample to result is reported at 24 to 48 hours, with 1 in 8 samples taking more than 72 hours in July. Capacity has grown to 19 laboratories testing more than 3,000 samples per day, with some decentralized sites now at 6 to 24 hours, but remote gaps still delay isolation and contact follow-up. Tracing reaches 82 to 83% of identified contacts, yet only about 16% of the projected total contacts have been listed. Operations are under fire and underfunded. More than 160 attacks on health workers have occurred since mid-May, driven by fear and mistrust, refusal to release bodies for traditional burial, misinformation and insecurity in the East, ambulances stoned and burned, facilities assaulted, blocking alerts, safe burials, and tracing. About 158 health workers have been infected and 45 to 46 have died. Military protection covers some sites, but no comprehensive new security plan is detailed. Funding is nearing exhaustion within weeks. Initial plans of about $240 to $518 million now face revised needs of about $940 million nationally and up to about $1.4 billion broadly. With pledges from the United States, United Kingdom, and European Union only partially dispersed, leaving teams, fuel, protective equipment, and community engagement at risk of shrinking just as killing accelerates. That leaves the open question answered in part and unresolved in full. No licensed tailored protection exists to replace the surrogate, and whether the Zaire vaccine offers any meaningful human protection against Bundibugyo is unknown until the 20,000-dose Phase 3 trial reports, a bridge of uncertain strength over an outbreak that has doubled its daily killing, spread across an area larger than France, and remains mostly undetected. Like and follow for more stories that matter.